Well, good morning, everybody. I'm just gonna share my screen. It's a real
Yeah,
pleasure to be here. So thank you very much for having me. This talk is going to be primarily about HER2 positive breast cancer, and while it is quite scientific in its description, we're not going to go through all of it because I think it's much more important that we focus on the context. And as was just explained, finding innovative ways to bridge this access gap that we have and find ways to access these sorts of innovations and these new molecules. So I wanted to start really by exploring where we've come from really along this breast cancer journey in HER2 positive breast cancer. And we've really come a long way. In fact, if you ask most breast oncologists now, you'd say this is really the area of breast cancer that's had the biggest transformation in the past 20 years. We've become so much better at personalizing treatment and maximizing the chance of cure in the early setting. And this is really the crux of what I want to focus on because as much as we've made progress in treating advanced or metastatic disease, and we really have, the main focus should always be on preventing relapse and minimizing the chance of recurrence. At the very least, delaying recurrence for as long as possible. That is the most important goal and should be a priority focus in any setting, regardless of resources. That is where resources need to be prioritized and concentrated. So I think it's always good to start with an overview like this to show where we are in 2025, how we manage this sort of thing. And we're primarily going to focus on the stage 2 and 3 cohort of patients. Um, and I'll just give a brief overview of what we do, at least nowadays in the UK. So if we start by looking at some real world evidence of the chance of survival and where we've come across all types of breast cancer, hormone positive, HER2 positive, triple negative, or what we currently class as triple negative, we can really see the challenge. And this is really what it's all about. This is the challenge that we have, the green being HER2 enriched or HER2 positive breast cancers. This is fairly old data. We've come a long way since then, but nevertheless, this is the challenge, and this is what most of the world is going to face. So if we look at very early breast cancer very quickly, primarily for stage 1 breast cancers in this space, it's going to be very simple. You perform surgery first. For the majority of patients, that will be a wide local excision, sentinel node biopsy. And the standard of care really for most of these patients now is to give paclitaxel and trastuzumab, which came from the APT trial. And we have good evidence, even though it was a single arm trial, the outcomes are excellent for these patients. But as with anything else, people then looked at ways to try and get people off the chemotherapy. And the data was quite interesting. I think the toxicity was more interesting, really. And from a patient perspective, looking at the quality of life, they really seem to benefit a lot more from this approach. This is not the standard of care in 2025, but nevertheless, so-called negative trials or trials that don't change the standard of care are still very important to us. They tell us quite a lot of information, and it gives us areas to explore, to understand where the direction of travel is heading. Because overall, patients who did not have chemotherapy just had a much better quality of life, which makes sense. And then, of course, this has led to Attempt 2.0. Again, all of this is not the main focus of the talk. It's really just there to show where we are going. And in early breast cancer, the focus is primarily on minimizing toxicity and de-escalating treatment. Can we spare these patients chemotherapy? And if we do, and we give, say, TDM1, can we give less and achieve the same output? That is where the direction of travel is heading, de-escalation. But for now, the standard of care for these patients will remain paclitaxel and trastuzumab for the majority. And there are still debates about whether you need to give a full year of trastuzumab or just 6 months. There are trials looking at that. But nevertheless, the aim in these patients is who can we de-escalate safely? But this is really the bulk of what we wanted to discuss. It's those patients who need neoadjuvant treatment. These patients primarily are those who have tumors that are 2 centimeters or greater, or lymph node positive, or both. These are your prime candidates for neoadjuvant HER2-positive breast cancer. And this is a massive cohort of patients. Because it's a relatively aggressive tumor, these are the ones that often slip through the cracks in screening. They often occur in between, so-called interval cancers. These are the ones you really want to catch. And the outcomes can be excellent if we catch them within this stage. So this is the optimal patient, really, for neoadjuvant HER2-directed therapy. Why? Well, we will look through a series of trials in brief detail that really validated the use of pathologic complete response rates as a biomarker to guide prognosis. And PCR now is really the gold standard for these neoadjuvant trials in HER2-positive and triple-negative breast cancer. It's a validated biomarker. We know how useful it is, and we can very cleanly stratify patients post-op into clear recurrence risk groups. We can also tailor their management in the post-operative setting, which we'll discuss later. But this is the most important endpoint, and it's an endpoint that by definition you cannot achieve by performing upfront surgery. And that just summarizes that patients who have a pathological complete response just have a much better long-term outcome compared to those, which makes sense. They're more biologically sensitive to this treatment. So what do we use? And really, this is the crux of the issue. In the UK, in Western Europe, in higher resource settings, we have access to pertuzumab, and we use a combination of pertuzumab and trastuzumab with chemotherapy for these patients. But this is not the case for the majority of the world, and we need to find ways to bridge this gap. Now, there are several trials that looked at this. Neosphere is the most seminal of them, which initially showed the value of adding pertuzumab to what was then the standard of care a long time ago. It's a very old trial, so it still used FEC, which we don't use anymore. But it showed that the addition of pertuzumab to trastuzumab increased the pathological complete response rates, which makes sense. This benefit was sustained over time. There were then 3 other trials, Trifina, Berenice, and Train2, which had many similarities, and they all validated the endpoint of pathological complete response as a biomarker to guide prognosis and showed the efficacy of pertuzumab in achieving it. But they also looked at cardiac safety. And Trifina, the primary endpoint, was cardiac safety, which is very important. We know that trastuzumab has a risk of affecting cardiac muscle. So if we're adding another HER2-directed agent, are we increasing the cardiac risk? That is a very important endpoint in practice. And of course, when you're curing patients, what you don't want to do is increase their mortality and their morbidity from other issues like heart disease. So what did it show? Very simply, it actually showed that the ejection fraction was relatively preserved and similar across both arms, which is what we knew from previous trials, but it's good to see it in a high quality trial. It also confirmed, again, that most patients achieved pathological complete response. So it showed us very important and very substantive data that dual HER2-directed therapy or dual HER2 blockade increases your rates of PCR while maintaining cardiac safety. So tick 2 very important boxes in practice. And Berenice, again, confirmed more of the same. But again, in the interest of time, I will just move through these quite quickly and just showed the key parts, which really, in this case, was that it did not substantially increase the cardiac risk. The cardiac rates, thankfully, of severe events, grade 3, grade 4 events, was still very reassuringly low. That's the most important thing. Train 2 the most important conclusion from this really is that it showed us that we don't need to use anthracyclines in these patients. And we know that anthracyclines, doxorubicin, epirubicin, whichever we use, increases risk of cardiac damage in a different mechanism to trastuzumab, but nevertheless, there is a cumulative risk. And so this changed our approach by showing that you did not need it. In fact, a non-anthracycline regimen was better. It showed us that we can safely avoid anthracyclines and decrease our cardiac morbidity even more. And so since this trial, the majority of centers now would use docetaxel and carboplatin plus pertuzumab and trastuzumab as the standard of care in the neoadjuvant setting, which is what we do routinely. But what about the adjuvant setting? In these patients who've had neoadjuvant treatment, or these patients who haven't, what do you do? To begin with, for these patients here who had primary surgery, because of course, while it's not the ideal pathway nowadays, it still happens in many places, and so this data is still very important. What do you do for these patients who've had primary surgery? And if you give them dual anti-HER2 blockade? So at ESMO Breast a couple of months ago, they presented the latest follow-up for this, the final follow-up for this, almost 10 years of follow-up. And what it really showed is that in these patients in particular, those with lymph node positive disease, there was a clear overall survival benefit over the period of study. And in fact, it showed that for patients who are lymph node positive, we should be adding pertuzumab. This is a very important point in practice, because again, when we're dealing with resource constraints and resource prioritization, we cannot look at approving therapeutics across the spectrum for everybody. We need to focus on those who can derive the most benefit from it, will have the highest clinical utility. And for this, it's those patients who are node positive, which is a very important thing for us to define, which is why I look at these two slides. The first slide is intention to treat or intent to treat population. It looks good, but when we look at the node positive subgroup, that's really where the benefit was. There wasn't any benefit in the node negative cohort, which is nicely shown by this slide, which is just a very important point in practice. Just moving on. So now that we showed that pertuzumab, the addition of pertuzumab increases efficacy and maintains safety, the next step was then deciding if we can find a way to improve the patient experience and improve the experience of the healthcare provider. So pertuzumab on its own is intravenous. Trastuzumab was intravenous and is now primarily subcutaneous. So then they decided, well, if we combine the two into a single fixed dose formulation, both subcut, would that have the same efficacy? Because logically, that would improve both chair time, nursing time, clinician time, etc., and patient experience, cutting down the in-hospital time significantly. And they ran two different trials, Federica and Francesca, which confirmed two things. It confirmed that the use of pertuzumab and trastuzumab together as a subcut preparation had the same efficacy and safety. And then the second trial looked at the patient experience, and the patient experience was very positive. And that's really what I wanted to show here in Francesca. Quite dramatic. 85% of them preferred subcut, 14% preferred IV, which makes sense because what most people would want. And since this data came out, we then transitioned our patients to the dual subcut formulation, including those who are already on treatment. Very clean, very straightforward, easy to put them on. So that was important from that side of things. We've shown that pertuzumab makes sense, it's safe, it's effective. We've then shown that there is a better way to deliver it, a way that's potentially more cost-effective and certainly more clinically useful. But what about those patients who are in a higher risk group? What about those patients who do not have a complete response to dual blockade prior to surgery? Those patients with residual disease, we know they're doing worse. We've seen the data. What do you do for them? This is where TDM1 came in. This is where we started looking at trastuzumab emtansine as a way of escalating those patients. So if we go back to the start, in early stage patients, in good risk patients, the priority is de-escalation. Can we get away with less? Can we spare them the morbidity, spare them the excess risk, spare the system the excess cost? For those patients who don't have a good outcome, the ones with higher risk, can we escalate their treatment? Again, part of this push for precision or personalized medicine. Can we intensify their treatment to get better outcomes? And the Catherine trial was the seminal study that looked at it. There are a few very important things. The majority of these patients at the time only had trastuzumab, but there were some patients who had pertuzumab as well, which makes it important, but the majority had trastuzumab alone. And I looked at those patients who then had residual disease. But 20% of these patients did have another HER2-directed agent. So while it's not fully representative of what we do now, there was still at least enough patients where we could look at this cohort and see whether it's relevant in 2025. And the difference was very clear. If we're looking at disease-free survival, in this case, invasive disease-free survival, because in breast cancer trials, they exclude DCIS, the difference is very clear, and the difference increased over time. So the benefits increased over time, which is a very important thing. And with adjuvant trials, we always have to consider that you use disease-free survival quite often to approve medications because you don't have the time to wait for overall survival in many of these patients. It might take 15 years to see a real overall survival benefit in some of these trials where patients do well, and you don't want to deprive patients of access to these sorts of innovations. So the standard of care is TDM1, and the OS benefits also spoke to that. So what does this really mean? What does this really mean for us? And I'll skip through all of this because I really wanted to focus a lot more on the practical side of this. Anyone can talk about the data. I just wanted to explain why we are discussing the things that we are, to put it in context. The reality is breast cancer is expensive. Cancer is expensive. HER2 positive breast cancer is very expensive. These molecules are not cheap. They're not accessible to the majority of patients. We know that. We also know that the higher the stage, the higher the cost. And that is very clearly proven. But nevertheless, this is still the reality. Whatever the resource constraints in our systems, we are still going to see these patients. We're going to have to deal with them. And in situations where we do not have access to neoadjuvant pertuzumab and adjuvant TDM1, we're going to see more stage 3, more stage 4 in particular, where the costs are highest because we're treating them for the longest period of time. This is the critical area to focus on. Can we keep more patients in the early setting through improved diagnostics, multidisciplinary team workflows, faster access to surgery, neoadjuvant treatment, etc.? Can we improve their outcomes through accessing these medications and keep them in the early setting, keep them in remission, keep them in a state of recurrence-free survival? That is really what we need to look at. If we look at data that we have from Trinidad, and this is data that was done here. This is data done by Dr. Nixon and her colleagues, and it's amazing, valuable data. We look at the cost. If we treat them in the early setting, if we treat them in the curative setting, the neoadjuvant and adjuvant setting, these prices are in US dollars, but it's irrelevant. What we really need to look at is that it is approximately 50% more expensive to treat them in the metastatic setting first line compared to treating them in the neoadjuvant and adjuvant setting. That is the bottom line, because that is what we're going to see more of. If we then had patients who needed subsequent therapy, and the majority will, if you need subsequent metastatic therapy, second line therapy, the costs increase again. You're talking about 130% compared to the neoadjuvant and adjuvant. So there is a very clear rationale for optimizing the early pathway. There's an economic rationale apart from a patient-centered rationale, which merits wider stakeholder involvement, because clearly this is not a sustainable situation, particularly when We consider the fact that the majority of these patients are often younger. They're patients of working age. They're patients with family commitments. They're productive members of society. So keeping them in remission adds increased value to society, not just in terms of their communities, their family networks, and all of these important things, but economically by getting them back to the workplace. So there are multiple layers of benefit that one could accrue by optimizing the treatment early on. So again, this data I mean, this is honestly amazing data from St. James. It looked at the cost savings versus chemo alone, and it's incredible. So by bringing these innovative therapies, we actually are generating a huge amount of saving. We're preventing metastasis. It's just a fantastic case. Likewise, if we look at the quality adjusted life years, and I'll discuss what that is shortly. Again, you're just giving patients better quality of life. You're making them more likely to return to the workplace, return to family, and increase their value and their contributions to society. So it's a win-win for everybody. And of course, as we discussed, it just reduces the likelihood of metastasis. So this is the final slide I would focus on in the last 2 minutes. How can we bring these agents to our setting? How can we do it? It starts with health technology assessments. That is the fundamental principle, the fundamental tool for assessing the value add of any of these therapeutics to society. And that involves several different pillars. The first is it clinically effective? Which makes sense. That's the most important thing. Is it clinically effective? The second is it cost effective? So you review all these trials that we discussed to show clinical effectiveness. You then look at cost effectiveness. So how many quality adjusted life years would it add? And there are different calculations that we already can do in Trinidad, say through UE, for example, where we can calculate the quality adjusted life year benefit. Third, is it safe? Again, looking at the same trials like Trifina, Berenice, etc. Is it safe? Are there new side effects? How do they compare to what we already have? And finally, what is the wider stakeholder impact on the system and society as a whole? Does it need new staff? Does it need new equipment? Does it need new reagents for testing? Will it change, or how will it change the way patients access care? So it's a very comprehensive way of assessing the value of it and deciding whether this is worth the investment. So health tech assessments, mandatory. Secondly, of course, negotiation with pharmaceutical companies who make these, which is done everywhere. And finding ways to get confidential pricing, patient access schemes. There are lots of flexible arrangements that individual states can make with pharma companies to get it done. Clinical trials, of course, would be the best, most direct and cost-effective way to get access to these at least early and get them before they are approved, so we can at least be at the forefront of progress. And of course, within CARICOM regional collaboration, we can leverage our economies of scale and the potential that we have, because individually, our power is not as strong as if we worked together as a region. International collaboration through larger bodies, of course, very important because there are different funding and cooperative streams we can access. Biosimilars and generics. Even in the UK, for example, there are biosimilars of trastuzumab that are used. So these are proven, they're validated, they're effective, they're a lot cheaper than what exists, and we have to be practical. We have to find ways that we can at least access good quality products for our patients. Local guidelines, and I know that's going to be a core focus here, very important. Regional guidelines important, but local guidelines also important because each state has different resources, different priorities. That's just how it is everywhere. So for example, maybe we only look at pertuzumab in the neoadjuvant setting, not the adjuvant setting. We only look at node positive patients, not node negative ones. At least find some middle ground where we can get access to those who need it the most, instead of blanket yes or no. And finally, formulary reform, which I know is a very important priority area. Once a drug is approved and tendered, it doesn't mean that it should stay that way forever. We always need to reassess what we have for relevance. Is this still good? Is this still the standard of care? Are we using it appropriately in line with our guidelines? Is there wastage? Is there excess usage? Because if we minimize waste, we can free up resources. If we can remove drugs that are no longer relevant, we can make space for drugs that are. And this is a cost neutral or even cost saving way to access new therapeutics without a significant upfront outlay. So this is really where we can focus our energy. And I mean, a lot of this already exists and is being done, just at different stages in different places. But it's the sort of thing that we just need to do. So finally, we have made tremendous progress in HER2-positive breast cancer. It's a very satisfying cancer to treat. Women come in very sick, and you can deliver excellent results and give them a transformation in their quality of life and their survival. And it's very rewarding to see it. But we need to make sure it's accessible. We need to think outside the box, leverage the creative potential we have in the Caribbean to bring these solutions. And just because there are new drugs and they're expensive, it doesn't mean that it actually costs the system more. It actually can save a lot of money for the system by bringing them in. And that's how we have to approach it. So yeah, appreciate the chance to speak. Appreciate your time. Thank you very much.